Before we get started, a friendly heads up that today's video discusses anorexia nervosa, eating disorders, and personal safety, which some viewers may find sensitive or emotional. Please feel free to skip this one or take breaks as needed. Your well-being is important. So today we have a guest, Dr. Jamal Essayli, who is going to help undercomplicate the topic of anorexia nervosa. Welcome to Undercomplicating Stuff, where we, two psychologists and coaches with over 40 years of combined experience, share our insights to help undercomplicate important topics. A friendly reminder that this video is meant for conversational and entertainment purposes only. Please see the information section of this video for additional resources. So I'm Dr. Julie Radico. I'm a psychologist, a coach, an author, and a speaker, and I'm here with Dr. Stacey Gideon.
Hi, I'm Stacey Gideon. I'm a health psychologist and the founder and CEO of a healthcare consulting and professional coaching business. And Dr. Essayli, can you please introduce yourself?
Sure. Happy to be here. Thanks for having me. Yes, I'm Dr. Jamal Essayli, clinical psychologist and associate professor at the Penn State College of Medicine in Hershey, Pennsylvania. And I do research and clinical work focused in CBT, which stands for cognitive behavioral therapy, and eating disorder. Today we'll focus on anorexia nervosa, which is one of the eating disorders that I research and treat, and also a little bit about CBT and some of the research that I do in developing therapies for eating disorders as well.
We're super excited to have you here and to have the perspective of a clinician and a researcher, I think is really unique. And maybe to start us off, can you describe what is meant by anorexia nervosa, including the symptoms, the signs, and things that you tend to address?
There's the DSM, Diagnostic Statistical Manual for Mental Disorders. That's where we kind of define whether someone meets criteria for a specific disorder. So anorexia nervosa is kind of defined by three primary criterion. One is restriction of energy intake. In other words, really extreme or severe dieting, kind of bordering on starvation or semi-starvation, really significant food avoidance that results in concerning weight loss. A little bit of weight loss. It's so concerning that the medical complications that define anorexia nervosa make it the second most lethal psychiatric disorder. I believe opioid use disorder is the most lethal, with anorexia nervosa being the second most lethal. So these are, really concerning degrees of restrictive intake or, again, severe extreme dieting. So that's sort of the first criterion. The second one is fear of weight gain or sort of distress around the idea of gaining weight. And the third criterion is body image disturbances. So really significantly poor body image or seeing weight and body shape as being super important to your self-worth or identity. And as I said, I'm a CBT researcher and clinician, cognitive behavioral. So we sort of formulate anorexia nervosa from a cognitive behavioral perspective. The idea here is that someone develops beliefs about the importance of thinness, more specific weight or bodies. They develop beliefs that is ideal or super important and important to who they see themselves as a person. And because of that, that develops these reinforcement cycles where they feel good or are positively reinforced by weight loss or behaviors that are associated with weight loss, like avoiding specific foods or skipping meals. And they are negatively reinforced, which means the disorder is kind of maintained by avoiding things that feel bad, such as anxiety or fear or shame around weight gain or eating foods that they consider to be associated with weight gain. So there's kind of this positive reinforcement, feeling good for thinness, that drives the eating disorder, as well as the negative reinforcement, avoiding behaviors that make them feel bad, such as eating a normal amount of food, or gaining weight. So that's kind of like both the sort of DSM description of the disorder and then kind of a CBT formulation of it too.
This is such a huge topic, and we're so excited to have you here because you do really thoughtful, important work with clients and research to really try to help people see the importance of deciding what feels healthy for them in an informed, thoughtful way. And as we're starting to talk about this, I just want to name really big, heavy factor that our social media, the world that we live in, where we're all looking at ads all the time, or celebrities, or just like influenced by what's going on around us, being sent messages. Like, how do you encourage people navigate social media and weight?
There's been research that kind of, I think, fairly reliably shows that overall more social media use, especially sort of image-oriented social media apps like Instagram, can increase risk for body dissatisfaction and disordered eating, especially in vulnerable populations like adolescent females in particular. In general, one of the biggest risk factors for eating disorders is dieting. And that means that social media that's very diet or weight loss focused will then be kind of like the riskier types of content on social media when we're talking specifically about eating disorders. So I think there's research that shows that it's not necessarily how much time someone spends on social media that might increase risk for eating disorders, and it is sort of like how they're using social media and the content that they're really focused on. Someone who is spending a lot of time interacting or viewing weight loss, dieting type of content, those are people who are increasing their risk for disordered eating. And kind of one of the things that we recommend is for people to kind of avoid or find ways not to keep reinforcing the algorithms to keep giving them more weight loss or body image content. The thing about social media is that it is measuring the amount of seconds that someone is watching an ad or whether or not you comment or like it. Before, there were magazines in stores that maybe they could choose to pick up. Now, on a social media app, the app is recognizing in subtle ways, like amount of seconds looking at an app, how interested a person might be in this weight loss video or image. And then as a result, can give them more of those images. And if that person's amount of time spending like looking at those images continues to be heightened, it further reinforces more of it in an algorithm. So it kind of, you can see a way that it accelerates exposure to that potentially harmful content. So in general, one of the recommendations is doing one's best to like quickly exit out of those or do everything that you can to unlike and discourage kind of exposure to that. Even when you're exposed to weight loss or dieting messages on social media, there are individuals who think about those images in ways that also increase their risk versus others. And really, it seems like one of the big risk factors is negative appearance comparison. In other words, if I'm looking at images of people and seeing them as more attractive or having more ideal bodies than me, and then viewing myself and my body negatively, I'm comparing myself to these images in a way that makes me feel bad about myself. That also is a risk factor for driving disordered eating. However, if I'm able to look at those images and do none of that sort of like negative comparison, these are, if not Photoshopped, edited photos in specific ways, or these people live a life that's like extremely different than the life that I want to live. Like their entire life is being sort of an Instagram model who is working out constantly and trying to aim to have like a specific body. And also that's like not like how I value myself for my life. And I don't then view myself negatively. Sort of that way of thinking about those images also can be protective. So long-winded answer, but yeah, there's a kind of a lot in here too, more than just like social media bad. It's kind of like the specific content and then also how someone interacts and thinks about that content too.
That's a great perspective, and I'm guessing ties really well into the cognitions and the behaviors that you help people with and having to tackle both of those. You'd mentioned that a vulnerable population are female adolescents in particular, and thinking about encouraging them to cut back on social media, I imagine, is a challenge. And there are other barriers that people face when they're struggling with this. For example, I remember an adolescent coming in to my office years ago with her mom, and her mom said, "Oh, she's just trying to get attention." And it took a lot to explain that was really a misconception. Are there other myths or misconceptions that you come across in your line of work or in your research?
Definitely, yeah. And one, I want to say that it is true that being a female adolescent is more of a vulnerable population. And at the same time, I do want to also kind of quickly say that a misconception is sort of thinking that it's only often like white, affluent adolescent females that eating disorders and anorexia nervosa impact because there is increased pressure for women to look thinner than men. I think current like society sort of values thinness a bit more in women than it does in men. I think sort of like eating disorders that look like drive for thinness and weight loss is like sort of logically more likely to emerge in women, where with men, because of there also being a little bit of this pressure to have a muscular and lean physique, we see sometimes things like steroid use in men more so than women. So I think the way that eating disorders can look because of the different sort of gender pressures by society can result in like different types of disordered eating pattern. But we do see anorexia nervosa and eating disorders in men across other genders, across all races. So that is one sort of misconception. Just want to state too, like it's both true that adolescent female is a high risk population, and it's also true that eating disorders affect a much wider population than that at the same time. And because of the stereotype that eating disorders only affect a certain population, it means that sometimes people who don't fit into that group feel more shame about having an eating disorder. And there is research indicating that men with eating disorders are often less likely to be detected as someone with an eating disorder who needs help, and less likely to seek help because of that increased shame that they have around having an eating disorder. Related to that, another population that is underdetected are patients who are not at low body weight. And I think so another really big misconception is that you can tell someone has an eating disorder by looking at them because they look malnourished or underweight. The reality is that the majority of people with eating disorders are not underweight. Technically, anorexia nervosa, one of the criterion is having a significantly low body weight, but just as prevalent, if not more prevalent, is a disorder called atypical anorexia nervosa that we've been developing and researching more and more over the last 10 or 20 years, 10 to 15 years. And atypical anorexia nervosa describes people who have the same clinical disorder as anorexia nervosa, same clinical presentation, but their body weight isn't technically, by medical terms, significantly underweight. So these may be individuals whose natural BMI is higher, and when they engage in really concerning and medically complicated, severe restricted eating, their BMI is in the normal or overweight range, for example. These individuals may be praised even more so for the weight loss that they experienced, and are less likely to be detected as having an eating disorder, less likely to see themselves as having an eating disorder, and don't look like they have an eating disorder if that's sort of a stereotype of what anorexia nervosa or an eating disorder looks like. If anything, individuals who are at higher body weights actually are at increased risk for eating disorders because they experience more pressure to lose weight. And as we said earlier, dieting is kind of the most reliable risk factor that we know of for eating disorders. And so those who are at higher weight, who have higher pressures to diet, are then kind of logically going to be more at risk.
You're bringing to mind a patient that I had seen on an inpatient service in the hospital several years ago who had the atypical presentation of anorexia, and they had spoken about that they had just gotten tons of positive reinforcement from their physician around losing weight, and that like they were in the hospital because of complications, because they were restricting their eating so much and it was really dangerous to them, but because they were in a body that didn't appear to be the like typical presentation, that they were like, but every time I saw my doctor, they were like, good job, keep going. And it just reinforced all the unhealthy beliefs and the unhealthy behaviors.
Yeah, exactly. Yeah, that is extremely common with individuals with atypical anorexia nervosa. And even those with more typical anorexia nervosa who don't even have a history of being at a very high weight, or maybe they were just like a little bit over the median, and also talk about going to a doctor. They lost weight from their last medical appointment and the doctor said something positively, or adolescents who will say that the doctor commented on how much like weight they gained from their last visit to their most recent one, even though it was like a very like normal, appropriate amount of weight to gain. Doctor sort of warning about it, and then we have the patients having a lot of like anxiety and distress about it and leaving that doctor appointment, then deciding to like change their eating in really significant ways. So education about eating disorders is improving. I think there's still a big need for more education to physicians and medical providers, because they're the ones who are typically the ones to talk to people about weight. Having that eating disorder education, I think, is an important thing for us to continue to advocate for.
It is such an important important distinction and thoughtful way that people need to have conversations, whether it's a medical professional talking to somebody or like a loved one. I'm mindful that you hear stories of people who have had like a significant illness and have lost some weight, and people are like, oh my God, you look amazing. And it's really not reinforcing a healthy thing that happened to them. And so, what might you encourage people, say you have a loved one who you are either concerned about their weight or want to check in with their health, or just like, how do you have conversations about like health without centering it on weight? Like, what recommendations would you have?
Yeah, I mean, I think you're getting at kind of a important distinction, which is the difference between weight and health. And I think we so often see them as the same thing, and we see weight loss as good slash healthy, and we see weight gain as bad slash unhealthy. So I think that being another myth. I mean, when I work with eating disorders, I'm constantly working to educate them about weight loss being unhealthy, dangerous, potentially lethal, talking about the benefits of gaining weight and gaining body fat. Yeah, so in terms of, what to do with loved ones, I think trying to not keeping the focus off of weight is kind of the key recommendations, and kind of focusing on maybe kind of what you're observing or seeing. So if you're observing pulling back on eating or avoiding specific foods, I think that's helpful information to share, kind of what you're seeing. And you kind of already said it, Julie, loving non-judgmental approach. And I think it's helpful for us to all think about, if we were struggling with a mental health concern, how we would want someone to approach us about it, especially if we were pretty anxious about sharing it with somebody. Most of us would want someone who's loving, non-judgmental, caring. And so I think taking that approach with a loved one or someone you care about, if you're very concerned, like, being persistent about it, maybe as uncomfortable as it is, like, in that loving, caring way, repeatedly trying to talk to that person and say, I'm worried about you. This, I'm seeing this. You want to talk to me a little bit about what's going on? And finding professional help, like that's my number one recommendation, is like finding professional help for people who need it. There are professionals like us whose job it is to help treat these things, assess these things, support people with eating disorders. And so really the number one goal is, how do you get your loved one to us? Offering to go with them, if they do acknowledge that there has been a challenge, whatever they can to support getting them and connected to help. We'll post resources as well, and places to contact if they're looking for support. But I think that's great recommendations for a loved one that you are concerned about maybe having an eating disorder. The importance of us being thoughtful about our own comments that we're making about weight and eating. Are we speaking about our own weight or body fat in a negative way? Because when we are speaking negatively about myself, like, I feel like I look fat here and I'm using that in a negative way, that's conveying this message about appearance, weight, body fat as bad things. And that also can impact the people around us. So that's another recommendation, is just to be thoughtful of the messages that we might be sort of self-deprecating. We're not thinking about others, but that might still end up having an inadvertently sort of negative impact on the people around us.
I really appreciate you bringing that up. And I'm sure it happens all the time where we're not even thinking and we're making a comment, like you said, maybe in a self-deprecating way. And the people listening could definitely take that a much different way. That wouldn't be helpful. And it reminds me to be more mindful. So thank you for that. I'm also wondering about the treatment options, outpatient, inpatient. Let's say someone is ready to be evaluated. What are some of the options for treatment, and how does one know what level of care is needed?
As you just noted, there are different levels of care for eating disorders, because anorexia nervosa in particular can be really medically complex. Sometimes patients need as intensive as inpatient hospitalization. They are monitored daily to ensure that they are safe and that they are being sort of refed in a safe way. There's something called refeeding syndrome, which can be dangerous and potentially lethal if someone who's been significantly restricting their eating kind of too quickly jumps into increasing their energy and food intake, causing sort of major complications. So that's one of the things that sometimes need to be monitored in medical settings. So a variety of like eating disorder symptoms, like purging symptoms, that can be really dangerous as well. So typically there's an interdisciplinary team of providers who are involved in the care of someone with eating disorders. I'm a psychologist, so my expertise is more in the behavioral health realm, which means I'm often assessing when I meet someone how successful can they be at improving their eating following what's called a meal plan, where they're given gradually sort of increasing amounts of food typically, and also asked to increase the variety of the food they're eating. On a like behaviorally, how successful can they do that just meeting with a therapist once a week for an hour? Or do they need something like the next level up, which would be an intensive outpatient program? So here at Penn State Hershey, we have an intensive outpatient program that's about 3 hours a day, 3 days a week. And then another one that's the next level up, which is a partial hospitalization program, which is 6 hours a day, 5 days a week. So in that partial hospitalization program, they're getting 2 meals and a snack each day. They're getting a lot of meal support while having to do some of the meals on their own. And then at inpatient or also residential facilities, which are also 24/7 facilities, they're getting all their meals done with staff to support them. So that's like one of the things behaviorally, like what are they actually going to be successful and capable of doing? And then there's the medical assessment too. So a medical provider here, when we have patients get referred to our division, the medical provider is also looking at labs and vitals to make determinations from a medical standpoint. How often do they need to be monitored? Do they need to be monitored daily because like weight is so low or the way they've been eating has been so restrictive that that risk of refeeding is high, and so that they really need to be refed initially in an inpatient setting. So these are the different kind of medical and sort of behavioral considerations for level of care. My research focuses psychotherapy treatment development. So my goal is to try to develop new therapies for eating disorders and improve the effectiveness of treatments. Right now, there's two leading outpatient treatments for eating disorders and anorexia nervosa. So FBT, that stands for family-based treatment. That's the leading treatment for adolescents with anorexia nervosa. And then CBT, or cognitive behavioral therapy, is the leading treatment for adults with anorexia nervosa and other eating disorders. But both treatments still result in the best sort of recovery rates. So FBT, family-based treatment, helps up to 50% of adolescents who are in the clinical trials at least achieve full recovery by 1 year follow-up, meaning after a year after they've done the study, are they still sort of recovered? So up to 50%, typically less than that. And then CBT, it's like 30% of adults. So we see a lot of patients can make some progress, but many patients make some progress, but not full progress. Relapse and can be high. So patients can make gains and recover, but it's complicated. And we're working on trying to contribute to new treatments or alternative treatments. How do we improve these recovery rates? That's kind of, the goal that kind of drives most of my research.
It's such important work, especially knowing that the treatments that are out there are helpful in some ways, but really not able to help everybody that they need to be helping. And so along those lines, what have you found are like the biggest contributors to the development of anorexia nervosa? What's sort of like getting in the way of the treatment being as effective as it could be?
And anorexia nervosa for decades now has been like notoriously known, having a reputation for being one of the most difficult psychological conditions to treat. I think one of the aspects that complicate the treatment for anorexia nervosa is ambivalence about recovery. In other words, sort of mixed feelings about whether or not they want to give up having anorexia nervosa. There's this term called ego syntonic, so sort of a jargony word, but it means identifying with the disorder. So anorexia nervosa is typically ego syntonic, meaning that most individuals with anorexia nervosa have a sense of pride and integrate the disorder with their identity. Earlier, I was saying that there's a sort of positive reinforcement mechanism that's driving or contributing to the maintenance of anorexia nervosa, meaning like the thinness, the weight loss, the success with restriction, all of that can be positively reinforcing and come with feelings of joy and euphoria, power, control, and again, a sense of identity. And so I think that's one of the things that can make it really challenging to treat, because unlike most other mental health disorders, those patients would say yes, if you could use a magic wand and just get this eating disorder, this mental health disorder to disappear, they would say, please use your magic wand to make that happen. Anorexia nervosa, a lot of the patients don't want that magic wand to be used in that way, or they're at least uncertain if they if it should. Often there's like a mixed feelings. Often when they're coming to us, they recognize that the disorder is unhealthy and that it's probably net negative effect on their life. Yet they're still really worried about giving up sort of these positive benefits. And another area that I've really focused sort of my research on is the fear of weight gain piece, sort of that negative reinforcement component. I feel like a lot of prior treatments haven't done maybe the best job of helping understand within each patient why weight gain is scary for them, what they're worried about will happen to them in their life if they were to gain weight. I think because weight gain is just sort of in society, as we just discussed earlier, seen as like a bad thing. And we're getting all these messages all the time that weight gain is bad and that thinness is good. That also complicates the treatment a little bit. And I think even clinicians themselves and researchers in this area have taken for granted that patients are just going to think weight gain's bad. Of course they will, because we all do, without actually stopping to think, wait a minute, like, why does this individual patient in front of me think weight gain is bad? What does it mean for them? And so the kind of treatments that I've been developing are focused on trying to really understand the consequences of weight gain for each patient. Why do you think weight gain will be bad for you? And patients might say, like, I will hate myself. I will be abandoned by others. I will become so sort of like depressed that I won't really be able to like live a happy life. A wide range of different reasons about why they predict weight gain will be bad for them or their life. And that understanding, I find, or I theorize at least, is going to help us be able to better treat it. Because if we know what their feared beliefs are, we can better be able to talk about them and target and potentially change them in treatment, with the goal of them learning that, okay, the catastrophic beliefs I have about why weight gain is bad maybe isn't the reality.
The research you're describing sounds incredibly interesting and definitely needed because of the recovery rate being so low. And we've identified already so many things that impact and maybe perpetuate disordered eating. And I'm wondering, with the proliferation of weight loss medications, what your thoughts are about that, what you're seeing, and any suggestions.
Yeah, GLP-1s have become very popular very quickly. So the truth is that the research is kind of well behind the actual usage of GLP-1s. So we are like, feels like in the last year, people are starting to ask and try to research this question of the interactions between GLP-1s and eating disorders. Dieting is seen as a risk factor for eating disorders, and GLP-1s make dieting easier. Eating disorder researchers and clinicians do worry that GLP-1s may increase the risk for eating disorders because, again, we're giving a very big dieting to many people, and it's very easy. It's getting easier and easier to access. Actually, speaking of social media, my friend, who's a researcher, sent me an Instagram ad. You're only this size, and you think GLP-1s can't be for you because you're, not heavy enough. No, this GLP-1 program is specifically for people like you so that you can get into an even lower body size. I'm trying to avoid like the numbers they were using, but it's already low numbers. And then when I because I shared this with my colleague, I've been getting this advertisement all the time. Speaking of the algorithm, like thinking it knows what I want. So now I'm getting the company sending me Instagram reels or whatever about weight loss using GLP-1s for people who are not at higher weights. So most people prescribing GLP-1s don't have any eating disorder experience or training, and that we're recommending that they receive this training, that individuals be assessed for eating disorder risk before they get prescribed a GLP-1. If someone has an eating disorder or past eating disorder history, making sure that that is accounted for and perhaps not prescribing a GLP-1 if they have active eating disorder symptoms, monitoring for eating disorder symptoms after prescribing a GLP-1 to ensure that someone does not develop eating disorders. There's a lot of clinical recommendations that are based on kind of limited research. I think we're going to find out more in the next few years, but yeah, so we'll see. But I don't know, my big recommendation would be if you are someone who's prescribing GLP-1s, consulting with eating disorder colleagues who have that expertise would be really critical. And and really just for all of us, patients, the general public, continue to ask ourselves the question about appearance versus health. How much of the treatments you're seeking are related to health and how much are they related to appearance? Because they are so hard to disentangle because, again, we've associated again, high weight with unhealthy and thinness with health. And again, I think we're slightly getting better as a society at starting to break that association, but it's still really strong.
A lot of people profit off of people not feeling satisfied with how they look or how they feel in so many ways. And it's just such a really important topic and thoughtful work that you're doing. And I'm glad that there are like clinicians and psychologists and researchers like you trying to create helpful, informed, evidence-based treatments for people. So there are so many key takeaways that are rushing to my mind throughout this whole conversation. And I think one of the things I would hope our listeners carry with them is really being thoughtful about the language that they use around weight and food and appearance and this idea of body neutrality and that your body is a vessel that helps you do things that you want to do in life and that it is something for us to care for and nourish, but also is never going to be perfect in whatever company is trying to sell you on what perfect is that day, because perfect keeps changing. And, people, it's an impossible standard. So really being thoughtful about the language that you're using internally towards yourself, but also what comes out when you're around the people that you care about, the people that you love, the people who are learning from you and how you treat yourself, and just to really be gentle and kind and mindful in that language.
Some things that stood out for me were the assumptions that we can make. And some things that you had mentioned, Jamal, were things like it only takes place in affluent Caucasian female teenagers, for example, and that you've cleared up that that is not the case. And then you mentioning atypical anorexia. I was not familiar with that. And again, that just because someone doesn't look a certain way or what you think they should look like if they have an eating disorder doesn't mean you shouldn't pay attention when you're noticing things that may seem to be unhealthy.
One of the things that I did, prior to this talk was I myself wanted to kind of look into the research on social media because I kind of knew a little bit about the risks with appearance related and dieting related social media and that increasing risk factors for eating disorders, but kind of delving a little bit more and recognizing that there are ways of using social media that can increase or decrease those risk factors. As I talked about, using social media in a way that causes you to view yourself negatively compared to the images or videos that you're looking at, that really is like one of the ways that it increases risks for poor body image or eating disorders. So I think really reflecting on whether or not that's something that is true for anyone listening to this, like true for your experience, and maybe trying to do your best to find strategies to challenge that. So like notice whether or not that is true for you. Are you someone who does have a tendency to look at these images in a way that causes you to negatively compare yourself, and maybe take a pause, like identify those thoughts a little bit, what you're thinking. I don't know, like find ways to question them. Sometimes, a CBT question that we'll ask a lot is if you had a friend that you cared about, or you had a son or daughter, and you had heard them say that thought, like what would you say to them? Often we're better at being able to provide healthy and accurate recommendation when it's somebody else than when it's us or when it's in our own brains. And so that might be a useful strategy that I was just sort of thinking about that was kind of tied to that social media piece. Like if you're noticing you're doing that, what can you do? And then for parents, having a discussion around the way their kid uses social media. I think there's a whole wide variety of approaches here where some parents may decide to limit altogether social media use or phone use for their teens. Some may limit it to a specific amount of time. So lots of different approaches. And another one might be if they are using social media, trying to talk to them about kind of what they're seeing and how they might learn to think about the things that they're seeing.
I think you brought up so much helpful information in your takeaways. One is the question that Stacy and I love, which is like, what would you say to somebody you cared about if they were having that same thought or thinking that same thing? And then also the importance of encouraging parents to be having thoughtful conversations or just even like considering like, how is my child using or being influenced by social media? These are really important impacts that and questions that people need to be grappling with. And so hopefully in our conversation today, that has given people some good ideas and places to start in thinking about this. So if this topic resonated with you, please share it with somebody that you care about. You can also find resources about our discussion today in the description of this video. Also, please comment, like, and subscribe. You can listen to our podcast on YouTube, Apple, and Spotify. And you can also message us on our social media platforms with questions that you'd like us to discuss in future episodes.